Okay, I think we're going to get going. So welcome everyone to the noon meeting. This is a weekly webinar that's organized by the School of Public Health. For those of you who aren't part of the school, if you're joining for the first time, welcome. We organize a weekly discussion about an important public health problem or issue. And this week, we are hosting a discussion about what communities are doing around COVID. It's part of a project that I've been involved with Hannah and health committees from different communities across the metro, and in fact even in the Eastern Cape, others for a long period of time. But the most recent project is really focusing on giving voice to health committees in the health system. And when we started the project, there was no COVID, and then COVID arrived, and so it's taken a lot of energy from the project, but also shown how communities can organize themselves to do things. And that's why we've titled this COVID-19 Communities Doing It For Themselves. We have a few speakers from Manenberg, Gugulethu, and Khayelitsha. And then Hannah will also, my colleague Hannah Harichanran will also make a few comments about what UCT has learned from this collaboration, because it's part of an NRF grant around community engagement, which the NRF encourages as a strategy, and which our Vice Chancellor has commented on in various research reports. So we think this would be a basis for a useful discussion. So I'm going to kick off and introduce Marianne Kinnis, who's from the Manenberg Health Committee, which is part of the bigger Klipfontein sub-district. And she's going to share with us for a few minutes what their perspectives, what they've been doing, and how that could be a learning for all of us. So thanks. Over to you, Marianne.
Thank you, Prof. Good morning, everyone. So what communities doing, our communities do it for themselves. Next slide, Anna. So we raise awareness in our communities around, we started by empowering ourselves through strengthening our committees through training our committee members with confidence and skill to be able to facilitate workshops for themselves. Included the COVID-19 when the pandemic hit us. We empowered our health committee members to be aware of what COVID is and what the vaccine is. So we had workshops with our elders in our communities, our youth groups, our churches, our schools, homes. Members went to individual homes to speak to people around the COVID-19, the pandemic, and the vaccine, and our street committees and our neighbors. So we also had workshops around our CHWs, that is our community health workers, and in the ways that we could explain the local issues that affected us in the pandemic. Next slide. So the pictures are all, so the pictures also speak to this that I'm representing. So communities were part of relief by helping in soup kitchens, helping people in with existing soup kitchens that is here. So we, like the Manenberg People Center, were one of the NPOs that helped some of our committee members in strengthening their own kitchens and helping with funds. So we were involved in distributing of food, masks, sanitizing packs. So barriers due to fund running out for kitchens has to close. Some kitchens had to close down because they ran out of stock, and so they couldn't sustain themselves. But some of the bigger conduits and bigger NPOs still continue to help smaller kitchens and continue to have links and partnerships. So those are some of the kitchens that are busy in the community. So the information that we shared, next slide, Anna. So the information on vaccines that we had, so with our seniors, with our youth groups, and so we distributed pamphlets, we did workshops with our youth groups and our seniors, schools, churches, and we designated those pamphlets. And so many of our healthcare workers, so we trained volunteers on the vaccination sites as well. Next slide. So we have done research in partnership with UCT. So we completed a community research. We implemented and used our skills to conduct an independent research by doing a telephonic survey. So that survey was understanding the experiences and responses of residents in the Klipfontein sub-district to the COVID-19 pandemic. Next slide. So we did some monitoring and advocacy work and interventions, other interventions. So the Health Committee engaged with the Department of Health around the vaccine rollout via our WhatsApp groups. We recruited individuals and now people to sign up for the vaccine. So the Manama People Center, one of the NPO in our area, mobilized the health committees and they used their own transport. You can see there's a picture of how the Manama People Center helped transport people with their bakkie to the vaccination sites. So doctors and nurses were escorted by the neighborhood watch in other communities to go to the frail care patients that needs to be vaccinated. So the health committee members also monitored some of the an old age home and raised a written complaint with the health department of how the lack of health and safety protocols is not adhered to. So health committee members use media platforms and official pathways to raise complaints. Next slide, Anna. So what have we learned as a health committee? That information sharing is important and that forms networks for us. Due to training where we could tackle challenges in the community better and deal with disinformation and fake news. We could inform our communities around the COVID-19 protocols and the symptoms of COVID. The training made us aware of how we as health committee should conduct ourselves to impact communities and to impact different platforms. The training has impacted the attitudes and awareness of individual health committee members, and based on this, all members were vaccinated and have positively impacted or spread the message around the vaccine into the communities. Through the training on vaccination, we could confidently spread the correct message of vaccination in a positive and respectful way because we were confident of our knowledge and we could discriminate between fake news and misinformation. A lot of health committee members were forced to attend online meetings and WhatsApp, and this improved their skill and confidence with using technology to impact their community and to engage with stakeholders and officials. Next slide, Anna. So what can the health services do or improve? The Department of Health must acknowledge the work of health committees because some members are nominated according to the Health Act. By ignoring community participation and the health committee voice officials are flaunting the Health Act. Officials often do not come out to community because of perceived danger, but health committees live within the community and directly emerge in what is going on locally. Communication barriers existed between the Department of Health and health committees, and often there was a one-way top-down communication. Health committees continue to work in conjunction with local communities, and often there was no support from the official health sources. Communities had to source their own means to educate themselves with the help of the People's Health Movement, as this organization saw us as equal partners. So NACOSA informed the health committees that the Department of Health should work with health committees with a workshop that we attended, and that workshop help us to set up a meeting with the Klipfontein Mitchells Plain Health structure to force them to work with us. Only after that there was more equal communication, but this is not entirely entrenched yet. 99% of health committee members are volunteers and are unemployed, so the distribution of power rests with the Department of Health, who is not leveraging that power to enable health committees to do for themselves maximally. Health committees often could not participate in Zoom meetings, team meetings, and WhatsApps. So health committees had to rely on local NGOs for infrastructural support and access to email and internet. The language often used in Zoom meetings were not understandable and empowering. The health committees forged links with the local municipality health services, ward councillors and sub-councillors. And as communities, we feel that there should be stronger links between the Department of Health and the local municipal health services. Next slide. Thank you for listening.
Thanks so much, Marianne. That was very clear. You're going to take questions at the end.
Yes.
Please hang on to your questions. And we'll have Mdayi, who's from the Gugulethu Health Committee, will share with us.
Good afternoon, everyone. As part of, my name is Mdayi, as Professor already said, coming from Gugulethu, that is part of Klipfontein sub-district. As you see on the picture, as health committees, We are working with stakeholders. That's why we've called ourselves Health Forum. Stakeholders that are health related, like MCSJ, like COTEC. That is why we are Health Forum. As you see outside the clinic, is the problem that is happening when COVID-19 was started, when our people would just come to the clinic even without mask. As you see there, I'm standing outside the clinic, sanitizing people before they come into the clinic, because we find it very difficult as a Department of Health turning people away if they don't have masks. They don't provide masks, but we must be there as community health workers, as health committees, to provide some masks and sanitizer so that they don't turn them back home. Next slide, Dana. Guguletu and surrounding find it very difficult. COVID-19 came. As we know, our health system was collapsing before COVID-19. When I'm talking about collapsing, I'm talking about we had a health system that was already a haphazard. When I'm talking about collapsing and haphazard, it was not strengthened. It was the services. They said health for all, right for health to everyone. But when you come to the clinic, we were always complaining about the shortage of doctors, services that must be rendered to the community, social determinants of health, everything that was haphazard before COVID-19. Then it was worse when COVID-19 came to our area. People were dying, as we know that when we see the graph, even in July, where lots of people were dying and people didn't die because of COVID-19. Lots of people died because of lack of education, not knowing exactly what is this COVID-19. It was a virus that you cannot even identify. People were dying because of a fear. Come here now. As you see here, this is our health care workers. That most people that are vulnerable, that had to go door to door and go help our seniors at home, even those who cannot help themselves. But we find it very difficult for them to put their life in risk, because even the department didn't provide PPEs for them. So it was good for us as health committee to work with organizations like People's Health Movement that has provided the PPEs that I'm putting on the care workers, because they are the people, before the COVID-19, they used to go inside the house and go and help those who are needy, the seniors, clean out the houses and do all this kind of work that they're supposed to do. But in time of COVID-19, they have to stand outside and just deliver the medication. That was the worst thing of health department, not to provide PPEs for our people. They were the most people that were vulnerable, and they were the most people that died, and they were the most people that had anxiety and died beforehand because of COVID-19, because they wanted to help our community, and it was a passion for them to do the work. The next one, Anna. What we do as Health Committee and Health Forum in Guguletu and Klipfontein is to provide sanitizers and masks. And there were lots of complaints about sanitizers and masks and the hospital. And you will find out the department, when we request, they will say there is equipment that must be used for COVID-19, but when you request those equipment, you won't get it. So it was good for us as health committee to network with other stakeholders, to network with other organizations like UCT has provided for us, NFR has provided for us, People's Health Movement, those organizations that has really strengthened the foot soldiers that are doing the work in our area so that people can be cured and not die beforehand. What did we do? Can I have another one? The next one, Ina. Here again in this raining container. You can see how the container looks, where the volunteers are gathered, where our home-based care workers are gathered before they can go out. It's raining even in this container. You can see that the condition is really not good. But what I'm doing here and other health committee members is just to give them the education to motivate them, because what the thing that the department lack is go out and motivate their health workers, even their nurses. Even yesterday, when on my way to Mdayi Hospital, I was transported by one of the staff, and they were just said, "No, we are taking leaves beforehand, taking leave after a leave, because the department don't even come out and motivate us. We must disclose to the family if one of their members died, but the department won't even come and say there is a counseling for you as a staff." I think those things that we identify that really as community, when we appreciate the work that our health workers do and motivate them, we need to identify those things and say to the health department that what they like to do, they mustn't just put things on papers, good policies and everything, but they don't come back and motivate their staff. Here we are here as health committee, as Klipfontein, Manenberg and Kukuletu and Heiderfeld, motivating staff, motivating our care workers. But what the health department is doing, just putting policies on papers. Can we go again? Next slide. Here we come now to the vaccine. After we had COVID-19 trainings and educate our people, because we find it very difficult of all the myths that is going on social media, even on TV, when people see the picture of COVID, they started to be scared and feared and even don't want to go to hospital. And there was a rumor that if you go to hospital, even if you have your other sickness, you will go and fetch COVID-19. So here we were trained by People's Health Movement, MSF, about e-vaccine so that we can go back to our community. As you know, and check the numbers now, as Klipfontein sub-district, we can upload ourselves because of the training that we received. We didn't keep it for ourselves as health activists. We went back to the community and trained and equipped our community and try to identify all this lack information and give that full information about what is this COVID-19, why is it important for community members, your families, to be vaccinated. That's what we are doing now, and we are still going to do it. Yeah. Next, Anna. What we have learned as community health committees and health forum, we've learned that let us organize ourselves, because if we are not organized, there's nothing that we can do. Organize ourselves and try to network with other organizations so that we can be equipped more as we are. We strengthened even the partnership with Department of Health when we find it very difficult, as I've already elaborated that problem of PPEs. We hear on news every day that money has gone down from the pocket to the leg, from the leg to the shoes. They didn't even do the needs of, they didn't even provide resources that they're supposed to provide for those people that they are food soldiers and do the work. But what we have learned as community is to come together, as we see that people were coming from all the angles, doing soup kitchen, doing food gardening, and the problem of even of infrastructure in our areas. That was a main problem that we identified as health committees, because we cannot separate services of City Council and services of Department of Health. When we look at where we stay, what are the situation, what is the environment, we have to refer all those problems, the blockage When we find it very difficult, each and every street when it's raining, people are just swimming in the water, are swimming in the sewerage. So we work together with all these departments so that we can refer problems that we have identified. I think that we've learned more to work with other service providers, to work with other organizations that are doing also health-related issues. The next one, Anna. Next. Another thing that we have learned is that out of the volunteers that we have as health committees, we identified 10 from them to do a research, because sometimes we need to go back to the community and hear exactly what are their problems. So the research that we have done has helped us exactly to know exactly what did the people to think about. Did the people have a knowledge about COVID-19? What did they think about it? What is their future in this thing? What did they look forward on it? You know, when you do your research, it always comes with poverty that really it's a common thing that is happening in our area. But what I've loved in this research that we have done with EU City is to go. I used not to like research, people that are doing research, because they will not come back and report. But what I've liked and like about this research that we've done is to go back to the people and tell them exactly what are the findings, what are we going to do, and not promise them things that you are not going to provide, to tell them exactly why are you doing research. Yeah, thank you. Next. And now you're sleeping? So the last question is, what should the health system do? You know, as you see from my last slide, the MEC visit our clinic. When she visits our clinic, she will just end up outside and talking to us outside. Not even coming inside and see the real problem that is hindering us and hindering their staff. They don't even care about their staff. They just want reports. They don't do monitoring and evaluation, that is very important. And the problem of a budget that we fought in each and every meeting, when they hide their budget, we're still struggling to know exactly why the needs of a clinic are not, they don't provide what we want them to provide, because they are hiding their budget. You know, it's a pity that one time, 2 a.m., one of the councillors wake me up and said, no, there's no oxygen in Kukuletu Clinic. In that 2 a.m., I have to wake up Unoma French and phone Unoma French that, MBC, you cannot sleep meanwhile people are dying in Kukuletu Clinic. That time when I was phoning her, she had to go back and find out from the facility manager why there is no oxygen in Kukuletu Clinic. When we find out to the facility manager, we find out the provider, the service provider is in PE. Meanwhile, there are people that they can do services in Western Cape. So there are many things that we need to strengthen. Even the policies that they are making about us. We always say there's nothing about us without us. They're supposed to be involved when they do those policies. Even their staff are complaining about those policies that they are making, because there is no community engagement, there is no staff engagement. They are just sitting in boardroom and decide about us and do all these things. At the end of the day, there's no implementation of those policies. I think I'm done. If I must talk about the Department of Health that makes us mad, I will talk. You can see here in this last picture, here is the MEC outside the Kukuletu Clinic. We just talk the talk because we cannot walk the talk. We just identify and say things, and she just end up there, not even go inside and see what is happening inside the clinic. So this is a waste of time. Our health system needs really to be strengthened. Thank you very much. I'm done.
Thank you, Sis Mdayi.
Can I talk more?
There will be lots
Can
of
discussion.
Can I say
more? I'm warm now.
No. You're going to hold it for later. Thank you.
Okay,
So,
sure.
the third presentation is about Khayelitsha. and I think Hannah is going to present it for Khayelitsha, but Mr. Ndibongo may add to her presentation. So over to you. Hannah, you're still muted.
Okay, so sorry about that. Can you hear me now?
Yes, we can hear you now.
So I'm going to present on behalf of the Khayelitsha Health Forum. The presentation that I'm going to present is done by Tamara Sam. Last minute, she sort of had to go to an important meeting, and I think that is that's quite typical of this kind of work, that things in the communities happen quickly, and yeah, I'll reflect on that in my own presentation a bit later. So I hope this presentation runs relatively smooth. As Leslie said, Ndibongo, Ndibongo from the Health Forum is present and will be able to answer questions. So what have we done? So here Tamara reflects on some research we have done on COVID-19 to find out how the pandemic affected people, what their views were, and how their experience was of the health system. The Health Forum also selected 15 volunteers that were trained to do vaccination awareness and education within the communities, and they have done that in conjunction with MSF. In addition, the Health Forum has been part of a steering committee where they work with the Department of Health and other key stakeholders. So they are functioning in an advising role to the Western Cape Health Department. And here's some pictures of volunteers that work on raising awareness around vaccines. So they have both done awareness around COVID symptoms and non-pharmaceutical measures, and around vaccine. And what have we learned? We have learned that sitting and waiting for the department doesn't get us anywhere, so that we must create efforts and opportunities to understand COVID and to make sure that the health services are playing their part and that we hold the health services accountable. We have learned that under a pandemic, governments should ideally involve all stakeholders in the processes, and the stakeholders should require that the government is transparent at all time. But our experience has been that the government is not often open enough to share what has happened. For instance, around the vaccines and the batches of vaccines that they bought and then did not had to take back the AstraZeneca vaccine. And I know Tamara also wanted to go into patent laws. I think I'll leave that for another time, because we all know about the injustice of patent laws. What should health services do? So here Khayelitsha Health Forum says that they should involve all stakeholders in order to deliver an effective and clear program on how to deal with the pandemic. So they stress the importance of involving communities, because communities know what's happening on the ground. They should create a system that is transparent and where there is no corruption. Yes, we all know that that's a big challenge. They should have a monitoring system that get monitored, so the work that is done, we can see whether it works. And I'd like to add here that in Khayelitsha, there has been a group of monitors that are on site almost every day. Then the Khayelitsha Health Forum also suggests that the health system should make sure that communities and other key role players have resources to work, and that is always a challenge, that they actually do not get resources, and therefore they rely on organizations such as MSF, PHM and UCT to do community work that ideally the health system should support. Here again, some pictures of the communities working. I'm not sure whether this is from training sessions or from monitoring, but yeah, communities working. And that was it from the Khayelitsha Health Forum. I think I'll just ask whether Ndibongo has anything to add now. Otherwise, over to you, Leslie.
Well, I'm introducing you just to talk briefly about what UCT learned from this as well. So over to you, Hannah.
Yeah, okay. So as Leslie said in the introduction, this was a collaboration between health committees and health forums and the UCT's program on health and human rights. So in the next few slides, I'm just going to reflect, just like the community partners have reflected on their lessons. I am going to reflect a bit on UCT's lessons from this partnership and also some of the challenges. So what did we learn as UCT partners? I think we learned, first of all, that academic community partnerships can work well in both research and health interventions, and that both communities and academic partners can benefit from such a collaboration. Also, that each partners have different strengths, and that should be acknowledged and used. We also learned that communities have great unacknowledged capacities to engage in health issues in their communities, and also in the research that several of the speakers have reflected on. So, for instance, communities have access to communities. They understand what's going on. They understand contextual issues. They have linked with local stakeholders and local healthcare providers. From the academic side, they can often provide opportunities, capacity building, expertise, and resources, and they can sometimes open doors to academia and to policy influence. In terms of the community engaged research, we have concluded that it has many benefits. I think the main of them is that it can be used in real life in the communities. I want to say that we are planning at a later stage to have a meeting or an engagement around this research we have done on COVID. So I'm not going into the research in itself in this presentation. We also learned that we could successfully provide students with an opportunity to work in communities and actually to apply their research skills in communities. Then I want to touch briefly on what I think were some of the success factors for this project. I think the first one is that it was a collaborative partnership, that I won't say community and academics contribute equally. That's a term often used. I prefer to use the term meaningfully, that we each partner contributed meaningfully to most aspects of the project. I think an important factor which the community partners have reflected on elsewhere was that they were part of the project right from the start. So they gave input into the proposal and identified what it was they would want out of this project. I think the next success factor was shared decision making. So all decisions around this project were made by a steering committee which consisted of 4 health forum members and 2 academics. And the decisions were made jointly after discussing what we should do. The third success factor, I think, was that the collaboration was built on respect and trust. So we have worked for almost, I think, 12 or 13 years together. So over the years, we've worked on different projects, and we have built respect and trust for each other. And I think that long-term trust is something that's built over time, and I think that was very important for this project. The fourth success factor, I think, was that, as I have said before, we recognized each other's strengths and resources, and we knew each other's strengths and resources from previous work. And therefore, we could sort of engage and learn together. The fifth success factor, I think, is capacity building. And I think that's a very important factor in when you engage with communities, that there is a capacity and empowerment component, and that should be factored into the project and into the time you give to the project. I think the last success factor is that we had enough flexibility in the proposal. First of all, to shift our focus when COVID happened, so we could address community needs, and the community partners had enough autonomy to say, this is what is happening now, these are the needs that we need to address, this is the research we want to do. So that flexibility is very important, and we were lucky to have it. I don't think you always have that in research projects. What were some of the challenges? Obviously, COVID was a challenge. We had to, like everybody else, quickly shift our working mode to online and to telephone. The challenge for us was that connectivity in Khayelitsha and Klipfontein was sometimes a problem. Our community partners, in particular in the beginning of the project, did not have devices that could accommodate Zoom and Teams. So those were sort of great challenges. At times we have worked with WhatsApp, or we have had people on different platforms, and still we've had to sort of really, it has been a real challenge working in that way during this time. Community engagement is time consuming, and obviously even more with these challenges we've had around connectivity and COVID. I'm not sure I put it as a challenge, but I think it's more a requirement that when you engage different academic and community partners, it requires flexibility and openness from both partners. Sometimes you'll come from different perspectives, different agendas, different needs, different experiences. And obviously there are power dynamics, and there are different forms of engagement and different priorities. And all of that needs to be negotiated. I think the last challenge that we experienced was sort of the interface between universities and this kind of work. So universities have, and UCT have, a very bureaucratic, slow way of working. And that often doesn't work with communities where things happen very quickly, and there's a need to act quickly. And this was particularly around finances. So quickly communities would need money to organize a meeting or to be able to move from A to B, and the funding streams were just running far too slow. It was also very difficult to accommodate local providers, for instance, early in the project around catering, because the systems were just not able to do that. So what should, and I've called it, what should health system, UCT and funders do? I think, and I'm sort of just here repeating what my colleagues have said, that they should acknowledge the value of community engagement and community engaged research, and they should view communities as partners and therefore change their way of communicating, So a lot of people have talked about this top-down approach. And then they should put resources into community engagement. Currently, as my partner said, they have to get resources from elsewhere because they don't get it from the health system. I think for UCT, the lesson should be to enable and strengthen community engagement and community engaged research. So even though UCT has it as part of its social responsiveness policy that they should engage with communities, the systems are just not geared towards it. For funders, I would obviously like to see more funding for this kind of work. And I think funders should acknowledge the challenges of community engaged research and projects, that it is time consuming, that it requires a long-term view, and that it requires resources for ongoing capacity building. And that's where I will end. Thank you.
Thanks so much, Anna, and thanks to Khalicha for preparing that. I don't know if Mr. Ndibongo wants to make any additional comments at this point. If you don't, then we're going to open it up to the floor for any comments or questions. We have about 15-20 minutes left for discussion. Gavin, over to you.
Thanks, Lucy, and thanks for all the interesting presentations. So I note that the request for the health department is to acknowledge the value of community engagement and community partnerships. But that's probably there already. I mean, the health department certainly does do that, but that's not going to change much, I think, just acknowledging the value. So I was wondering from all the presenters, you know, are there practical things which the health department could do to improve community partnerships, and which are the sort of priority things that you think the health department should do? So you mentioned a few as well earlier, but again, I don't think that they so much high value. So, for instance, communication about the supply of vaccines and the use of vaccines, of the AstraZeneca vaccine. I mean, that probably wouldn't help much. You know, the AstraZeneca vaccine, the decision was made that it might not be useful, therefore we won't use it. Probably a wrong decision, but a decision made and out of the hands of the local health departments, the provincial health departments and local. The other one is supporting health workers. So the health department has in place a system of team leaders for community health workers and then nurse supervisors for them. So is that not support to community health workers, or is different support needed, or more support, or practical things like that, which could be taken back to the health department and say, look, this is what is required. Can you do it? Thanks.
Thanks, Gavin. Are there any other questions? Hannah, I've just posted in the chat, you're still screen sharing. You might want to stop your screen sharing.
Yeah, I will stop.
Are there any other questions or comments? So I don't know who wants to respond to that. So Gavin's basically saying, well, there are policies in place for health worker support. So what's going wrong there? And also the issue of the vaccine. He wasn't sure he saw that as being very helpful to communities to have more information about why AstraZeneca was suspended. So I can see Mr. Ndibongo. Right, now's your chance. Please go ahead.
Yes, thanks. You see this technology, I'm trying to get in when you call me, but I'm all not going through. Thank you, Anna, for the presentation. Then I was just going to add that the Cultural Forum has done engagement with the department in terms of even at the beginning of the COVID-19, because screening and testing was done only in Khayelitsha. And then that raised the number of people that get positive in Khayelitsha because we're testing. And after that, we engage with the government in terms of awareness and education, because what is failing the government, they do not do awareness and education in our communities. And I'm not sure whether they do have so-called health promotion officers, because now we're talking about the vaccine, we're talking about COVID-19. Now people were scared to go and vaccinate themselves because they do not differentiate. The vaccine is vaccine. I'm always saying that, because it's only COVID vaccine. So just because there's no awareness and education in our communities, people get scared. And also, I think the government was also worried about this pandemic thing because it was a new thing. So also systems of the government are not the same. Western Cape is different to the country. Now we have to fight before we get any help. We're not just going there and getting the help. For instance, now in health committees and clinic committees, we are not singing the same song, because clinic committees are not democratically from the communities, appointed by the government of the Western Cape. Now, that gives resistance with the community to work with them. So this is what I was going to add. Also, without these partners, more the UCT, because UCT, we partners as Cultural Forum before the pandemic COVID-19 came. We were lucky because we were trained, people called train the trainers. So those people were convicted to the trainers of the COVID-19 education, with the material that is supported by People's Health Movement, education material and other material. So this that I wanted that to add. For my apologies, because I was out when the presentation was done. Now I was scared to do the presentation. I didn't see, because secretary was involved all the time, because I had problem. Then we gave the mandate to the secretary. So this is what I wanted to say. So if the government can strengthen the community partnership and higher institution partnership, and we work together, then we can be able to achieve a lot. Thank you very much.
Can I go directly?
Thank you. So is there a response?
Can I answer the question?
Yes, Mdayi, please go ahead.
Yeah, question about the CCWs and the partnership with the government and the policies. The policies mustn't just are written on the book. It must be something that must happen practically. As we are in dilemma now, we are still talking about the recognition of our community care workers. That mustn't be sourced via NPOs like they did. The government must employ, the health department must employ the community care workers direct, not via the NPOs, because lots of money goes to NPOs, and the people that are doing the work, food soldiers as community care workers, don't get those monies. Even now, they are fighting for living wage. So policies are there, they made their policies, but they must involve the community on those policies that they are doing. Add more.
Thanks, Mdayi.
To add more, there's somebody that wants to add more.
I think in a big part, what Mdayi is saying is that the Department of Health essentially decides who the NPOs are that works in communities. We've also found this to be the case in Menenberg as well as in Heideveld, is that the Department of Health, without communicating with health committees or the centers, the local community health centers, they decide who the NPOs are that will provide the community health work services. And communities are not involved.
So thanks very much for that point. I think that's a very important point, because the way in which the department considers community engagement is sometimes reflective of the needs of the department and not the needs of the community. And I think Gavin's question really points to, the answers point to the problem that we have policies in place, but maybe they're not being implemented in the right way. And in fact, communities can tell you if they're not being implemented in the right way. So for instance, if Mdayi reports that a health worker is not getting support for the challenges of counselling a family, that should be something that the sub-district should know and do something about. Hannah, your hand was up.
Yeah, so I just wanted to give a few things that Gavin could take to the health department. So I think the first is resources. So we have health committees which are legislated both in the National Health Act and in the Health Board Facilities and Health Committees Act. But there are no resources. And without resources, health committees really struggle, not just during COVID, but all the time. So I think that's sort of one very concrete thing that the health committees could do. I think another very concrete thing would be capacity building. So ensuring that health committees are capacitated to participate in holding the health department accountable, in providing input into how to best address community needs. And I think the last thing is around communication, that to develop a form of communication so health committees are not only drawn upon when there's a crisis, but that there's a continuous form of two-way communication between the health system and communities. So those are the 3 points I would like him to take to the department.
Thanks, Hannah. Okay, Gavin, you're now the official representative to the department. Any other questions or comments? Anyone else want to raise anything? I noticed a few comments in the chat, which basically is agreeing with the presentations and sort of lamenting the absence of the sub-forum, the sub-district representation here. Are there any other questions people want to raise? Comments? Okay, if not, then I think we can draw the discussion to a close. I want to just thank everyone for presenting. There will be a follow-up presentation where we will talk about the research that was done with the health committees and UCT together, partly to talk about the findings, but also to talk about the process, because I think it's a very interesting process around how university research can be reconfigured in a way to be more meaningful to communities. We've also had a number of students participate with health committees, producing videos of community experience, working with health committees around important research questions around community voice, and those will also be shared. We had thought we would invite 2 of the students to present today, but the program was quite full, so we left it over for the next meeting, and we'll be in touch with you about when that next meeting happens. So I want to thank everyone for attending. Go well, and if you have any questions for any of the presenters, you're welcome to contact us, and we'll put you in touch. So thanks very much then. Thanks everybody, and thanks particularly to our speakers. Thanks.
Bye. Enkosi kakhulu.
Yeah, inkosi kakhulu.
Mawawa enkosi.